My name's Jacob. This is my case presentation for a client with cerebral palsy and obsessive compulsive disorder. So the client is 16, presented with cerebral palsy and obsessive compulsive disorder. She lives at home with two siblings, 10 and 19, so she's a middle child. Cerebral palsy means she has spastic quadriplegia, so on all four limbs. She has to use orthosis, ankle support, and a point of support for ambulation. She also suffers from left hips on her left hip sores also. The OCD, she presented compulsively needing to use hand sanitizer and cleaning every surface in her consultation. Now we know that OCD is going to really increase her feelings of anxiety and fear. And it's personally for her, she's increased her social isolation, which has resulted in decreased mental health. So from the client presentation, we've identified two client factors. So she's 16, so she qualifies as an adolescent, and also she having cerebral palsy, she has a chronic condition. So upon doing some research, we've located a meta-analysis and systematic review for behaviour change techniques for physical activity interventions in chronic conditions in adolescence. Now here, the title of this paper does say children. However, upon a further reading in the paper, the inclusion criteria was for individuals between the age of 0 to 18. So despite the title saying children, it could be a little bit misleading because our client's an adolescent, but with the inclusion criteria within the review, we know that this is a valid source for us to use. Continuing on, so we found a paper that actually aligns both client factors and synthesizes BCTs and the research surrounding them for eliciting physical behaviour change and adherence for adolescents with chronic conditions. And within the paper, it broke it down into both short and long-term physical activity adherence, subjective and objective measures of that. And in both short and long-term behaviour, we found there were 4 BCTs that stood out above the rest in their effect. These were instruction on how to perform the behaviour, behavioural practice and rehearsal, demonstration of the behaviour, and social support unspecified. The charts on the right here, they don't provide enough detail in specific statistical differences, but they do provide enough. They do provide a good visual representation of where the 4 BCTs that we identified, and how they compare to the next most effective or the other BCTs that were included in the review. As you can see, there's quite a substantial difference. But just how effective was it? As we can see in long-term objective and subjective measures, as well as short-term subjective and objective outcomes, all the effect sizes, they're all positive, so none of them cross 0, and they all have a quite statistically significant effect size, so that we know we can talk about them, and we know we can talk about them quite confidently. Unfortunately, the paper didn't provide specifics for each individual BCT. It did provide us a range that all of the BCTs included sat in. Alright, so we know the client has OCD, obsessive compulsive disorder, which is quite a severe mental health disorder. We did some research looking for behaviour change techniques associated with positive behaviour change and exercise in OCD populations, but very little was found. However, we do know we could find that what research we could find in exercise in OCD populations is that despite it being very limited, exercise was shown to at least reduce symptoms. of OCD and aerobic exercise as well seemed to be particularly positive. There was no research done on resistance training in obsessive compulsive disorder populations overall for the reduction of OCD symptoms so far. However, we do know that resistance training still has other health benefits, so that's not to say that resistance training can't be performed by a person with OCD. From a behaviour or adherence point of view from exercise, what does seem clear, if anything, is that the enjoyment of the physical activity appears to be key to adherence for OCD. Now this makes sense for a few reasons. OCD can be quite a detrimental disorder to have, particularly in terms of social connection, because of the increased fear to be around, or the fear of germ exposure, real or not. But the important thing to note is that we know that exercise is more broadly been demonstrated to be an effective treatment for mental health in depression and anxiety. So that, especially aerobic exercise, I should say. So if we can use exercise to decrease general feelings of anxiety and also increase the enjoyment of the exercise itself, we may have some supplementary benefits there for OCD. So, plan A, we're going to implement those 4 initial BCTs, as we said, that were clearly above the rest. So, instruction on how to perform the behaviour. So, the EP or me, we're going to instruct each exercise and each session thoroughly. This is going to increase our levels of competence, which all aligns well with self-determination theory. If we can increase competence, I should say, behavioural practice and rehearsal. We're going to encourage and create consistency between, by completing 2 sessions per week for 12 weeks. So if we can create the behavioural habit there, again, we're going to increase those levels of competence. Demonstration of the behaviour. So we're going to send a video of each exercise of what we're going to do in each session 24 hours prior to the session to the client, which is going to allow for mental preparation. Again, the client doesn't have any surprises, could potentially help them with their anxiety going into each session, feeling more competent. And as far as social support, we're going to include and encourage the parents and the family to partake in some weekly physical activity. So maybe that they can. So essentially, if they can make it a group-based thing. It's going to make the physical activity more enjoyable and make the client feel a little bit more related, increase the relatedness feelings. So again, hopefully increase the physical activity adherence. The exercise modes, we have seen some light links that aerobic exercise is going to be great for or useful for OCD. But we also know it's really good for just general depression, anxiety symptoms reduction. But we're also going to include resistance training because of the health benefits and outcomes we can achieve from that, including increasing muscle strength and increasing motor function. But increasing enjoyment, we can do this by integrating volleyball skills and drills into the resistance training as like supersets, for example. The reason where we got this idea from, in the initial consult, the client did mention that they like volleyball, so there that's our first port of call for increasing enjoyment, something that they want to work towards doing again. So plan B, or alternate consideration. So there were 2 other effective BCTs shown in the study, the review we talked about before. They just didn't seem to be as effective as the other 4 that we've talked about, but these ones were action planning and graded tasks. So action planning, the client and the EP will collaboratively plan when and how each session and weekly plan will be laid out. So going into more detail than the 12-week plan we mentioned before. And also graded tasks, which will allow us to progressively increase the intensity and duration of the exercise at a manageable level so that the client doesn't feel overwhelmed. Again, this is going to align with self-determination theory, helping increasing feelings of autonomy and competence for the client so that they can better adhere to the exercise plan. Positive effect sizes are shown on screen.